Welcome to the part 2 of this lecture. I would now like to discuss antiretroviral therapy initiation and maintenance among people with HIV who have cancer. Among HIV-positive persons with AIDS-defined malignancies, in particular non-Hodgkin lymphoma, continuous use of antiretroviral therapy during chemotherapy is associated with longer survival and lower risk of opportunistic infections. Further, several reports show that intensive chemotherapy protocols are feasible in HIV-positive persons with acceptable tolerability in most cases. Indeed, treatment outcomes for treated HIV-positive patients with Burkitt lymphoma, diffuse large B-cell lymphoma, lung cancer, and Hodgkin lymphoma are very similar to HIV-negative patients receiving the same chemotherapy regimens, as you can see here in this figure. Whereas the blue line representing the HIV-positive group follows very closely the yellow line representing the HIV-negative group. On the basis of these encouraging results, there is growing consensus that HIV-positive persons should initiate or maintain antiretroviral therapy use while receiving cancer treatment. Among antiretroviral therapy naive HIV-positive persons with a newly diagnosed cancer, most specialists would initiate an integrase inhibitor-based regimen, which has less potential for drug-to-drug interactions and better tolerability than PIs and NRTIs-based regimens. The period required for cancer staging, pathology, molecular testing results, or insurance approvals is a very good opportunity to start antiretroviral therapy prior to chemotherapy. In HIV-positive persons already receiving antiretroviral therapy at the time of cancer diagnosis, antiretroviral therapy regimens might have to be modified prior to chemotherapy to reduce the risk of overlapping toxicity and drug-to-drug interactions, and also to improve adherence and tolerability. Zidovudine commonly causes anemia and neutropenia. The side effects can be exacerbated by chemotherapy. Therefore, zidovudine should be avoided in cancer patients. PI-based antiretroviral therapy have been associated with more toxicity and lower efficacy in cancer patients when compared to other regimens. Let's look at an example for potential drug-to-drug interactions involving protease inhibitors and commonly used chemotherapy drugs. We won't go into too much detail, but here we can see that there are various interactions which should be anticipated, depending on which type of chemotherapy is combined with the selected antiretroviral therapy regimen. Detailed information on potential drug-to-drug interactions is available at the Liverpool University website. In some cases, efavirenz use can be limited by drug-to-drug interactions and also by its very long half-life. Rilpivirine is a new NNRTI with a better interaction profile, but there is little experience with concurrent chemotherapy. On the one hand, integrase inhibitors, in particular raltegravir and dolutegravir, have an overall favorable drug interaction profile and should be considered in cancer patients receiving chemotherapy. On the other hand, elvitegravir boosted with cobicistat might have important drug-to-drug interactions. Maraviroc, a CCR5 attachment inhibitor, has a theoretical advantage in patients undergoing stem cell transplantation because CCR5 blockage might reduce the risk of graft versus host disease. Let's now focus on other clinical challenges during cancer treatment. The infectious disease physician should always partner with the oncologist to review drug-to-drug interactions, overlapping side effects, and anticipated changes in antiretroviral therapy and chemotherapy regimens. Decisions regarding treatment should be individualized according to the patient preferences, cancer treatment plan, including chemotherapy, radiotherapy and surgery, and other comorbid conditions. In those with a good chance of cure, cancer treatment may sometimes take priority over HIV treatment. This is particularly the case when patients experience severe or life-threatening toxic effects. In patients receiving efavirenz-based antiretroviral therapy, NRTI drugs should be administered a couple of days after discontinuing efavirenz to avoid functional monotherapy. However, if antiretroviral therapy discontinuation is required, an attempt should be made to initiate antiretroviral therapy as soon as possible. In patients with incurable cancer and higher CD4 cell counts, it might be reasonable, in some instances, to quit antiretroviral therapy indefinitely. CD4 cell counts, HIV RNA levels, and antiretroviral therapy adherence should be closely monitored in patients receiving cancer treatment. In patients with lymphoma, CD4 cell counts might decrease more than 50% during induction chemotherapy. Some experts recommend monthly monitoring in the first 3 months after induction chemotherapy and every 3 months afterwards. All currently recommended prophylaxis against opportunistic disease should be administered in patients with low CD4 cell counts. Sulfamethoxazole trimethoprim might have to be replaced with pentamidine or dapsone to avoid myelosuppression. In patients receiving chemotherapy and submitted to stem cell transplantation, prophylactic drugs to prevent cytomegalovirus and fungal infections might be required. Efavirenz should not be used together with voriconazole. Special formulations of antiretroviral therapy regimens and drugs are available. Patients with gastrointestinal intolerance and with difficulty with swallowing pills should receive antiretroviral agents available in special formulations. Of the 33 single agents and combination products from the 5 antiretroviral therapy classes currently available, roughly half exists as powders, liquids, injectables, or chewable or dissolvable tablets. All 7 NRTIs are available either in powder form, as with didenosine, estavudine, and tenofovir, or as an oral solution with abacavir, entrectinib, lamivudine, and zidovudine. Out of all the NRTIs, only nevirapine is available as an oral solution. 4 protease inhibitors, namely darunavir, fosmanprenavir, lopinavir-ritonavir, and tipranavir, are available as oral solutions. No liquid alternatives exist for integrase inhibitors, but raltegravir is available both as a chewable tablet and as an oral suspension. Further, dolutegravir tablets can also be crushed if necessary. Out of the 4 currently available dose combination products, only tablets of abacavir, lamivudine, and dolutegravir can be split or crushed and dissolved in semi-solid food or liquid. The only antiretrovirals available as injectables are zidovudine and enfuvirtide, which is a fusion inhibitor. To review, we have described cancer screening and workup strategies currently recommended for HIV-positive persons. We have discussed the indications for lymph node biopsies and when to start and how to maintain antiretroviral therapy in patients with cancers. We have also discussed the clinical challenges during cancer treatment, in particular chemotherapy and drug-to-drug interactions, as well as describing which antiretroviral therapy regimens and drugs can be taken in special formulations. Thank you for joining me for this lecture.